Hello, good evening, and welcome to another episode of EAO's Just Ask, your monthly live appointment with a leading expert in implant dentistry. My name is Gerrit Heijkoop and I'm the host of this EAO channel, and in this live video session tonight we are going to try to answer as many of your questions about age considerations in dental implants. And the leading expert with me tonight is live from Zurich, Spyridon Papageorgiou. Spiros, good evening.
Good evening, Gerrit. Nice to see you again.
Yes, definitely see you again, because people might recognize this duo from the EAO digital days in 2020, where we did a Tell Me More About session. Those sessions are still available in the EAO library if you're curious. And tonight we are live and we're going to try to answer questions, perhaps from Victor Pallery, who's joining us from Moldova, Marianne Manset joining us from Paris, Rafa Al-Hitti also from Paris with us, and Philippe is there. Mario Flores is joining us all the way from California. Good afternoon, I think, Mario. And also Nicole is with us from Stockholm. This is how it works. It's the live chat here on YouTube. If you have a question for Spiros about age considerations, please make sure you enter your live question there and I will read it out to Spiros as well. Now, before we get started, Spiros, let me introduce you, because you're not an implantologist. You're actually an orthodontist. And your official title is you're a senior teaching and research assistant at the Clinic of Orthodontics and Pediatric Dentistry, the University of Zurich. And from that background, you do a lot of research into growth of the face, growth of the jaw, growth of the skeleton. And that taught you a lot about how that relates to implant placement as well. And that makes you the perfect expert for this session. So I think by introduction, could you introduce our audience a little bit into what is happening in regards to the growth and the movement in that craniofacial skeleton?
Yes, thank you, Gerrit, for the nice introduction and of course for the invitation. Strange thing, I'm asked to come in as an expert in implantology, but I'm not an implantologist, so I'm an orthodontist. So we have the joy and the privilege that in our everyday work that we get to see children, starting from children and then accompanying them in long periods of lives. And through that, we can see how they grow, how the face grow, how the jaws grow. And through it, we can appreciate what big changes happen throughout the life of a patient. And for example, some typical, let's go to some typical pictures you can see for patients. So for example, we start with initially very young and small patients, and we see how the whole, let's say, the head of the patient, so the neurocranium and then the desmocranium changes through the patient's life, but also you can see that the proportion actually of the desmocranium, let's say, of the piece of the head that holds the brain changes, and how in the later life the jaws actually gain much more prominence, and we have a completely different proportions for the face during the patient's life. But what we can also see is that there is a big difference, both if we see the patient from the front or from the side, in terms of the size and also the relation of the jaws. We can see also that the teeth develop in a big variation throughout the patient's life. And for example, if you see the difference between the patient's age 3 years old, 7 years old, 11, 14, or even adult, let's say patients for now 18 years old, we have a completely different relation in size and form of the jaw that we see through adolescence up to adulthood. But the thing is that up to adulthood, we think that we have a completely developed skeleton, or at least a face for the patient. And the thing is that it is not that much the case. So if we start, for example, seeing, we can see clearly that there is, when you see the increment, so how much a patient grows within each year, we can see that we have, first of all, a difference between boys and girls, or men and women. This might be interesting for afterwards, but also that we see that even when the patient is 18 or 19 years of age, we have most of the growth that has already happened, but the growth is not zero. So we still have some small increments of growth. So what is important for us is that we start with children, but even when we move now in these decades with more adult patients, we can see that there is still some differences in the craniofacial skeleton. And
because I can imagine that Alberto is joining us from Spain and also Roger from Lebanon, and they see this data and they see these graphs and they all end at 18 spheres. They think, yes, of course, these are children. This is what we know. No implants in children under 18, right?
Yes, that would be the perfect case if it was an ideal world. Unfortunately, adult is a binary decision for us, that we say that the patient is adult for legal reasons maybe, but biology is not law. So if we see actually more clearly in detail how the growth goes, so we can see that even, for example, at 18, 19, 22 or 25 years of age, the growth has very much decelerated. So it goes very, very, very slowly, but it's not zero. So if you see, for example, the right side, the posterior growth of the whole face, even at 25 years of age, it is not that small. So it's not that big as we have in the gray area where you have the pubertal growth spurt, but it's not zero. So we have, even in adult life, so after 18 or 20 or 25 years of age, we still have some slow growth, as we tend to call it.
But then when I look at these graphs carefully, I spot the lines stop at 25. Is that because the research didn't follow the patients any longer? Is it because after 5 we don't consider? Or what happens in an adult patient?
Very, very good question. This is unfortunately a flaw of the study. It doesn't mean that it ends with 25. So first of all, let's start with 25. We can see that we have a big proportion of patients that have stopped growing, but not all of the patients. So if we define, if a stable patient is, for example, patients who grow less than 1 millimeter per year, and this is, of course, subjective, you could say that even 0.9 per year in a decade, it's a big amount. But let's say we take a cut of 1 millimeter, we can see that, of course, most of the patients have stopped with 25 growing, but there is still 15 or 25% of patients who still will show some residual growth. And if you see it even afterwards, so after the years of 25 or 30 or 40, we'll see that we have, let's say, about 1 millimeter per decade of growth, even among adults. So even older than 30 or 40 years of age. This is legally adults. They might have even a syndrome of their own. They have their families, but they're still growing in a sense. At least for orthodontics, we call it slow growth, which is a combination of growth and remodeling. But for all intents and purposes, for implantology, we still have some changes in the vertical dimension.
And I've understood that this is the most important term of tonight. Slow growth. This is a concept that the people watching should really write down in their notes, because this is the news. Even in adult patients, you say there's growth up to 1 millimeter a year. I mean, you just showed the graph with the difference between men and women. In women, you say 1 out of every 4 patients is still growing actively in an adult age.
Yes, I would like to go first back to the slow growth. So we have 2 different kinds of sports here. So we have the sprint running, which is the men. Like, for example, they tend to grow a little bit more between, let's say, 18 to 24 years of age, and then they slow down because they're tired. But you see that the women, they keep on growing. So slow growth, this is a marathon. So we're comparing now a sprint and a marathon. The men have, let's say, in the decade 30 to 40 years of age, they're growing less than the women, even though if they start, they grew more. But the women, they keep on growing, and only after, in the decade of 40 to 50 years of age, we see very, very small changes in the vertical
And just
growth.
to be super clear, the vertical axis on this graph is millimeters, and these are averages over a population.
And I have just changed it to not millimeters per year, then to millimeters per every 5 years, so we get a more than practical representation of how much growth we're talking about. So, for example, if it was a guy, if it was a man in between 18 and 24 years of age, this 1.8 millimeters just in 5 years, it's a very big difference. So I would say that maybe if I could avoid it, it wouldn't be the best age to place an implant in that patient.
Yeah, because let's dive into the world of implantology and what does this mean? So your research shows that patients keep on growing, and it's different in different types of patients. Maybe later we can dive a little bit deeper into that. But what are the aspects of the osseointegrated dental implants in relation to its surrounding both hard and soft tissue? What does this mean for implantology?
Yeah. So let's say that we have placed a dental implant and it has been successfully osseointegrated. So for all intents and purposes, we could accept that this implant is mostly, there is some hints that it might be not that much, but if you had placed successfully an implant, then this implant, then it has fused with the bone, it has integrated with the bone. So let's go back to the colleagues of the pediatric dentist. And if you remember some deciduous teeth that have been kept lower than the other teeth, it is because they have ankylosed, because they have fused with the bone. This is the whole decision, exactly the case we have for implants. So we place an implant and then it stays, we replaced it, although the jaws, as we said, continue to remodel, which means that we're going to have a difference in time between the still growing natural teeth and the implants that stay where they have been placed. So we can expect that there is a difference for example, in the position of the teeth in the dental implants with age. And the more we wait and the more we follow the patient to see it, the more this difference is going to be. So, for example, this was a nice. Let me check.
Yeah, and it's important to understand what I learned from you is that this growth it's both the jaw, the skeleton is growing, but also the teeth are also moving, growing, going in different directions, and that's where the implant, which is so fixed and stable, will differentiate from its surroundings more and more.
Very good point. So, we talked about how the jaws grow, but the jaws grow, but the teeth, they still keep in touch. I mean, even in contact, in full occlusion, even among adult patients. So it doesn't matter what we see in the bones, the teeth, the patients still get to eat, still get to talk, still get to articulate. So we can expect that we have some counter-reactive then development or eruption of the teeth. And this continues until the late adulthood. So even among patients being like 45 or 55 years of age. So it doesn't stop, it counteracts to the growth of the jaws. And we can see that the anterior teeth tend to erupt more than the posterior teeth. It has mostly to do with the jaws that they open up more in the anterior because they swing back. It might be associated with the thickness of the masseter musculature and also with the growth pattern, but not necessarily only vertical. So we can see that all the teeth, they tend to move also to the front. So we have a forward migration of the teeth throughout the adult life. So even after 18 years of age or 20 or 30 years of age. And this has nothing to do or only a small thing is dependent on the presence of the wisdom teeth. And it might be more for male compared to female patients.
Okay.
And together, these two actions, so the whole vertical slow growth of the patients and the mesial drifts of the teeth, in the end, they give you two big, let's say, adverse effects of osseointegrated implants that have been placed among natural teeth. One of them is that you can see that one tooth stays back where the other teeth continue to erupt. And you can either call it infraocclusion or infraposition. And this is, unfortunately, not a very, very rare effect. So it's very often. You can see it in every second patient. And it was a very big surprise for us when we first saw it with Christoph Hemmerle in 2018. Yeah.
I think you told me, yeah. So this is a few years back. And when I look carefully at the graph, what I see is you did a review of all the different studies and you compare how much movement or how much change do we see between the implant and the teeth? Is that what I'm reading?
Yes, exactly. I mean, it's the rate of how many teeth they had an infraposition more than 0.5 millimeters compared to the natural neighboring teeth. And then, of course, there is a big discussion if this 0.5 millimeters is clinically relevant for the patient or not. There is a big discussion. So not necessarily.
Where do you stand in that discussion, Spyros? And let me also invite our viewers who just joined us. We are super live, at least if you're not watching this in recording, but joining us tonight at Monday, September 5th. Then please submit any comments or questions you might have based on these findings that Spyros is presenting to us tonight. Spyridon, you say there's a big discussion whether this is clinically relevant, because in the end, it's small changes, less than a millimeter. Where do you stand in this?
There is some issue to think about. First of all, it might be small at this time, but the question is how it's going to be in 5 years, in 10 years, in 20 years. As a vague rule of thumb, you could say that the patient usually doesn't see less than 1 millimeter of difference between the neighboring teeth. Mm-hmm. And even if he sees it or she sees it, it doesn't always mean that they're not happy with the result. So sometimes it might be, but it differs from patient to patient. But you have to think that this slow growth, it decelerates, but it doesn't stop. For many reasons, remodeling, it might be some resorptive phenomena with the condyle, but it doesn't stop. So if we see, we can find some factors that are associated with faster infraposition or slower infraposition. So for some patients, this difference with the neighboring teeth is going to be more quickly bigger, or it might tend to slow down and not be that much. And these are different things that have to do both with the time we place the implant, let's say with the age of the patient, but also in how we actually then reconstruct on top of the implant. So we have, for example, some data that if you see the lower graph, you can see the different lines. So it means that for a 30-year-old patient, we can expect 1 millimeter per decade. So 0.10 millimeters per year, which could
of
be
infraposition.
Yes.
So you would say 0.1 on average. So after 30 years.
If you have, let's say, a patient who is 30 years of age, in 10 years, he's going to have a 1 millimeter step with the neighboring teeth. But if the patient, when we place the implant, he was 46 years of age, then he would have after 10 years 0.8 millimeter. And if he was, for example, 60 years of age, he still would get in 10 years, in a decade, a small step with the neighboring teeth, but this would be 0.6 millimeters, so not 1 millimeter. So it would be less. So the older the patient is, the older the age of the patient when we implant, then the smaller the difference is going to be in the next years. So we see some deceleration. So this slow growth, it gets even more slower with increasing age.
Because while I listen to you, Spyridon, I'm also thinking, okay, so how do we bring this into clinical advice, right? What are our scenarios? One of them is case selection. Maybe we should realize that in a very young patient, we should not consider those as a candidate for implants. That's something I've heard before amongst the EEO. But then what are other options we have or other considerations we need to think of when we have the patient in front of us?
Let me just supplement to the thing before it, that except from age, we might also see some difference according to the growth pattern of the patient. So if you have a thin, long-faced patient, then we might expect that in the same period, we might have some more infraposition compared to other teeth. But back to your question, what are our options? Our options would be clinically relevantly either to tell the patient that you're going to have an implant after some years. This could be an option for some patients, but of course, as the experts in implantology will tell you, if you wait, then you lose bone, then you lose soft tissues. So it is a compromise that you might have to do. And then you might have to resort to some regenerative procedures when you try to implant. The other option would be to still place an dental implant to the patient, but just inform the patient before you actually place the implant that, okay, it wouldn't be the ideal thing to do, but we can still do it. But you can expect this thing in the next 1, 5, 10 years. And then if the patient is okay with it, then you don't have to answer any awkward questions in the follow-up visits and asking, why did it happen? Was it your mistake, my mistake? Who's going to pay for it? And also for any follow-up interventions, because you might need to actually treat the patients even though you have no pathology.
Exactly. But then you would just treat out of either aesthetic or functional wish because of the intraposition that is created over time.
Yes. I mean, functional, it's going to be sometimes an issue if you have a very, very big step. Aesthetic, it might be for some patients, for some maybe not. It is very subjective in what are the aesthetic needs of the patient, what are their expectations from the treatment. But in terms of biology, you can't expect that even if you have let's say, a very big infraposition with the neighboring teeth, or if you have lost, for example, the mesial contact point, because there's another issue that you might have. So we said that the teeth of the patients, the natural teeth, they both developed vertically, so they go down, they erupt more, but also what they have is that they move to the front because we have this mesial drift, and this means that for the average patient that they have placed an implant, they might lose also the contact point with the mesial mostly teeth, sometimes with the distal, but mostly with the mesial, just because the implant cannot move to the front, whereas the neighboring natural teeth, they can move. So this is, again, every second patient. So it's a very common phenomenon in let's say, 5 to 10 years of follow-up that you will see that they have lost the contact point. And from a recent research, also from Thomas Gasser from Zurich, we saw that this is not only a problem that it is like trivial, that we lose the contact point, but also then if you have an open contact point, as the prosthodontist will tell you, then when you eat, especially, for example, fibrous food like let's say meat, then you get remains of the food within the teeth. And this is, first of all, it disturbs you, but also it might be associated with some periodontal inflammation. So there might be also some biological reasons to, let's say, for example, exchange the prosthetic crown and then restore the contact point again to the original situation.
Yeah, exactly. So let's go back to our decision tree. We are in the clinic. We are confronted, let's say, with a patient either with a younger age or with some factors. You already said a long face, perhaps, or a woman, perhaps, that we might expect more growth than others. Either we wait. Well, if wait is not a scenario, your advice tonight is make sure you inform. Because I can also imagine if you're in your early 20s and the dentist tells you you might have to come back in 10, 15 years, that sounds like really, really far away, right? So from a 20-year perspective, right?
Well, I have seen some work from the colleagues from Zurich, from Dr. Neni, from Professor Thomas, from Professor Jung. I mean, you can have solutions, especially in the 18 to 20, 22, 25, some, let's say, Maryland bridges or contemporary Maryland bridges, some provisional work that still will work for the next 2, 3, 5 years, and it looks perfect. You cannot tell that there is not an implant there. So it depends. If the patient is really young, then maybe you could try to persuade them to move this decision a little bit back. If you have older patients, then I think it's not necessarily. But again, I cannot give you a recipe. I'm not even an implantologist. Exactly, so this is just considerations, not recommendation, not suggestions, I'm trying to, no guidelines.
Yeah, no. But that's what I'm trying to learn from you, to see if we can understand the considerations, different scenarios. Let me once again invite our viewers who joined us later. Michael Payet from Austria, Larissa Music from Croatia, Thibaut de Jong from the Netherlands. If you have a question regarding age considerations in younger patients, make sure you make use of the live chat, just as you just did, to check in and make sure you post your question there. No, but what I would like to better understand is, okay, clinical options once we are confronted with such a patient. You already now add to the option maybe a provisional, but you already thought as well.
So delay the insertion of an implant, yeah.
Yeah, but then we might lose the bone as well. Is there any way there might be solutions either in the design of the solution that we like over dimension, whether we, for example, when we do a bone augmentation or we need to do something there, or perhaps in the prosthetics?
Again, no expert. There is some data that there is some difference between delayed and immediately restored implants. If you ask me, I have no idea what there is a difference. This is not my field. Theoretically, if one could stretch his imagination and, for example, say that you initially place a small crown on the patient, so smaller than the neighboring teeth. So when you have this infraposition, you can then get it back by placing later on a proper sized crown. This sounds interesting. I can tell you if it will work because
it's clear. We need to talk to a prosthodontics expert about that, whether how feasible that scenario is.
But the clear fact is that after, especially for example, if you have placed an implant too early in a patient, And in the end, you end up with a difference of, let's say, 2, 3, 4 millimeters between the neighboring teeth. Then it's just not just aesthetics, because you can see obviously that you have some difference in the bone levels. The patient, they cannot clean the superconstruction. So it means that you will have a niche of bacteria that it will get probably some inflammation there. So slow growth is not a very big problem. If we have an horizon of, let's say, 10 to 20 to 30 years, then it's okay. But if we have, for example, a patient that is 18 years of age and we're thinking about 2 or 3 millimeters between the next 5 or 10 years, then it could be a problem.
Could be a problem, exactly. Now, a crazy thought, but hey, we're thinking and working around this problem as well. When you say, I'm not an expert in prosthodontics, I'm thinking, well, you are an expert in orthodontics. Maybe this is basic osseointegration, but let's ask the question to you as well. Could orthodontics be a solution later on? Would you be able to move the implant, or is that exactly the problem with what we're dealing with here?
No. I mean, we have some data that we can move with heavy forces, some implants, but this is mostly our orthodontic implants, which are not completely osseointegrated. There are some experimental methods of using, for example, distraction osteogenesis to move the bone with the implant, but at least to my knowledge, there is no solid evidence. So we could still try it. There might be some good idea in the future for future research, but once the implant has been placed, the most successful attempts I have seen is unfortunately taking out the implant, then doing some regenerative bone procedure, and then placing a new implant. But let's say up to now, the most compelling evidence says that when you have placed the implant, it stays there and you cannot move it easily. You can very easily move all the other teeth back to the implant, which
could be another scenario, perhaps, yes. But I mean, it's very theoretical.
For cases where you have, like, let's say, not that young patient, you have 1 or 1.5 millimeter difference, then you could use the implant to intrude, so to make the teeth go a little bit more cranially, more up, so you can have an aesthetic solution. But again, then you might have to experimentally again retain all the teeth in the position of the implant, so they cannot follow the natural growth downwards. So this could be a reason, a solution, but if it's in the long term a viable solution, this is a good question.
I must say it also sounds a little bit like the other way around. If there's a lot of healthy teeth around, then we move them back to the implant. But if you're in a situation where there's multiple implants and a few teeth left, maybe that could be a scenario.
That could be a very good idea, yeah.
Question from Thibaut de Jong. He's making use of the fact that we are live and says this session is called Just Ask. So let me pose the question. Is there a difference? So I think he's referring to the aspects of infraposition or change over time. If the implant placement is in the alveolar or the skeleton bone. So he says, does it matter whether the implants are shorter or not? So either location or implant length, is that a factor in the expected?
So I take it he means mostly if we're in the alveolar bone or not in the alveolar bones. For example, there is some options of placing implants zygomatically. We know that the zygomatic bones are very stable structures, so they don't grow. But the zygomatic implants are, at least for most cases, not the average solution for the patient. So it is let's say a last call solution where we don't have any alveolus, because the alveolus is the part of the bone that holds the natural teeth. It has then resolved because we have lost the teeth, and then you cannot place an implant there. So it is a different situation, but still there is very, very small research on zygomatic implants in the long term. In the alveolus, we have some differences between the posterior teeth and the front teeth, because we have a bigger variation in the anterior teeth. So the front teeth, they move more to the front, because in the slow implants, so the adult growth of the patient, big differences occur mostly in the anterior area, not that much on the back teeth. So front, bigger difference than in the back teeth. But if you ask me between alveolar process and zygomatic bone, I cannot give you a very good question. I could imagine the zygomatic is a more stable bone, but if you think that the superconstruction has to go on the alveolar structures, then there is a big question mark.
Yeah, exactly. I understand, and we're going to dive deeper a little bit into the topic of the placement and the location of the implant. And what I like now that the discussion is getting started reminds me of the fact that later this month, if you're interested in discussing with peers about different solutions and making sure you have a conversation between an orthodontist and a prosthodontist and maybe a periodontist and an implantologist, make sure you mark your calendar from September 29 to October 1st and come to Geneva, because there it's time for the yearly EAO Congress, Uniting Nations Through Innovations. And the good news is you can still benefit from the preferential rate if you register now, because that's open until September 20th. And for those of you who can really not make it to Geneva, be aware that there's also an online program as well every night. And I might have a little bit of something to do with that. So then we meet again. Let's go to the next question. Roger Matar is asking, and it's your favorite question, I know, what is the minimum age to place implants in the aesthetic zone? And is there a difference, and that's what I was referring to, the front and the back, with the molar area? What is your answer? You told me you get that question all the time, so please help us understand.
Yes. Again, there is no cookbook solution. So theoretically, you would you might then tell your patient that the more we wait, the better solution we might get in the long term. But the patient usually doesn't care that much about how it's going to look in 10 or 20 years.
That's what I said earlier. If you're 2022, I think 35 sounds really old and really far away.
Yes. So I would say if you can avoid, especially for men, the 18 to 24 years of age. So I take most of our implantologists, for example, here in Zurich, they try to delay the patient up to the age of 22, 23, 24, 25. So especially for men, the period of 18 to 24, it might be dangerous because you have within just 5 years, almost 2 millimeters of growth. This is a big thing if you think in the next decade. But other than that, if you don't have a very vertical consideration, very high angle, so a vertical configuration, a long face patient, then you could theoretically with 22, 23, 24, 25 years of age implant, but just inform them you're going to have, for example, the next, let's say 10 years, some small difference.
Exactly. I think that is one of the most important takeaway of tonight. First of all, the phenomenon of slow growth, and then the advice to make sure that you inform patients, especially in the younger demographic, that this is a chance that could happen in the future.
I mean, if you have a 40-year-old patient, I wouldn't give that many thoughts about telling them about the infra position. It's that negligible amount that for the next 20 years of age, you might have, let's say, 1 millimeter of difference. So it's not a big deal. But up, let's say 20, 25, 30, 35 years of age, I would inform them, well, 35 years of age is pretty safe. But let's say in the demographic 20 to 30, I would just inform them that we still can place it, but we might have to adjust our prosthetic work afterwards.
Exactly. Roger writes a follow-up question. He asked about the aesthetic zone versus the molar area. Is there any difference between the maxilla and the mandible?
Yes. I mean, the problem is, what we see mostly is that the challenge is that the whole, let's say, growth after 12, 15 years of age is driven by the mandible. So the mandible actually grows or remodels, and the upper jaw, it just erupts in order to keep a contact with the lower teeth. So the upper jaw is more understanding and gives some space to the lower jaw, but the lower jaw is the main driver of the differences. Which means that the alveolar process, it doesn't necessarily grow that much. So the bone with the teeth doesn't grow that much with the lower jaw, and it is mostly the upper teeth that over-erupt to meet the lower teeth. So I would say that you could expect to have more eruption of natural teeth among adult patients for the upper than the lower jaw, and you could expect to have more eruption in the anterior area than the posterior area.
Exactly. Wow. Very well explained. And we got the questions fired. What do you like to add,
And of course, don't forget one thing. If you have one small step with the lower teeth, and it doesn't necessarily is a big problem with chewing, then the patient cannot see in the back teeth. They're more interesting in the front teeth if they're straight and they have a nice smile.
It's the whole game. Are we playing in the aesthetic zone or not?
Yeah.
The questions are lining up. So let's congratulations to our audience. You are on fire. Let me shoot off the next ones to you. Ricardo Heine is writing, what is the importance of maintenance or hormonal modulation in bone stability? I'm not sure I understand myself what this refers to, so please explain from the basics.
I mean, as far as I know, it's not that easy to modulate how much the patient will grow in the years. I mean, it is a very, very good question. If, for example, let's say patients with osteoporosis or with bisphosphonates, they react differently. So if they take medication that affect the biology of the bone, if they would react differently, I would expect them to. But this is something that you cannot necessarily know now. So I think it's stretching. I mean, up to now, where we are, the research is pretty thin, and it's not that many studies that have a large sample of patients that have followed them and have reported the results completely. So we still are learning which are the risk factors, but we're way, way far away from saying if we could theoretically, by using medications, then arrest this bone growth and then have stable implants.
Yeah, because that's the idea behind this, that you would place an implant early, and then in order to prevent problems further down the line, you would
topical injection, gene therapy, some fancy stuff, but we are
to stop the growth.
Way too early in this field.
You're not aware of any research into that. No. Well, thank you, Ricardo, for that interesting question, and
but very interesting for future research.
Exactly. Arifa Faroukwi, I hope I said that correctly, says, does the growth of the jaw, either maxilla or mandible, is being hampered in any way if the implant is already placed over there? So that's interesting. We said there might be a problem if the implant doesn't move and the jaw and the teeth are remodeling. Are you aware of any research that the implant might be a factor on this growth?
Well, not directly, but again, I will take you back from when I told you that let's extrapolate it to the pediatric dentist, and let's say that an implant reacts as an ankylosed tooth. So we have some research that if you have, for example, even on one side of the jaw, an ankylosed tooth, which means a tooth that has been fused with the bone, then the growth of the alveolus then is not the same as the other side. So it is logical that if you place an implant, then the alveolus will not develop that much as in other areas when you have natural teeth, because the implant keeps it there. But we're talking about the alveolus. And if you're talking about let's say the main body of the jaw, so the skeletal part of the jaw, then it might again grow, but then the alveolus, or the bony part that keeps the teeth, the neighboring teeth, it might then stay back due to the implant. But it's again mostly theoretical, and there is no that much evidence for that. But you could expect it to happen.
Exactly. So you say it happens, especially we see it happen in an ankylosed tooth. Could there be a different? I'm now thinking out loud along with you, visualizing. Could that then mean that if I have placed an implant on my, say, left side and not on the right, that there might be a difference between both sides?
No. I mean, the alveolus, especially in adult patients, is high enough. So even if the upper part of the lower jaw, it gets hampered a little bit in the growth, then the lower part of the jaw, it mostly can grow good. But again, we're talking about adult patients where the difference is not that big.
Exactly. Clear. Good question. Thank you very much. Mark Wertheimer, are you good, Spyros?
Yes,
we have a few more to come.
No, I know Mark. Let's see what he has to ask. He's not done this, so watch out. It might be a tricky question.
Is this the one you planted with him this morning?
No, I didn't.
Mark writes, one needs to take into account the amount of tooth/soft tissue exposure of the individual patients when at rest and smiling. This varies. There's no question mark behind that. He's actually adding to the conversation. Maybe you can elaborate a little bit on that, Spyros?
Yes. This is a complex question because, for example, if you have a patient that shows lots of teeth, then it's not the same problem as having a patient that shows only a small amount of teeth. because then even a small infraposition apically, it won't be necessarily then visible to the patient. If the patient doesn't see it, then mostly it's not a problem. And we have to...
Exactly. So now you define problem as an aesthetic problem.
Yes.
Right?
If we're talking just about aesthetics and not biology, but if Mark was so kind to bring us back to orthodontics, then let me show you a nice study comparing implantologists and orthodontics. So we have here patients that have been treated, they have missing lateral, so the second incisor tooth is missing. And in one scenario, the patients have been treated with implants. So we're talking about patients that are 18, 20, 22 years of age, so young patients. And then we have also patients who have been treated with space closure, which means that we didn't regard that much the aesthetics, and we close the spaces by bringing all the teeth orthodontically to the front. And you can see, for example, when you compare left and right, that the patients were much more forgiving than experts. So dentists, orthodontists, implantologists, orthodontists, they are much more strict, and they might find more problems in terms of, let's say, the gingiva being a little bit gray or having small recessions. But the patients usually, if they have one tooth there, they're much more forgiving. And not necessarily trying to avoid Mark's question. So there might be cases when we have difference between the how much teeth the patient shows. We know, for example, that gummy smile patients who are also usually vertically overdeveloped in terms of the maxilla, then these patients, if you have even some small difference with the neighboring teeth, so some small infrapositions, it might be a problem both for the patient, because when they smile, they will show you the difference and you will see it, and they will have a problem with that. So first of all, aesthetic approach of if the patient will understand this difference, but also patients who, for example, show much teeth, they usually are long and thin-faced patients. So you might expect for these patients to have more difference in the next year. So again, if you could theoretically buy some time by a provisional approach where you don't have in the first years that much a big step, then it would be best for the patient.
Exactly.
As a topic, tricky question coming from an orthodontist.
I know. And Mark says, thank you, brother. I know you know where I was going with that. I'm also a bit fascinated by something else I spotted in the graphs you just showed, is that apparently the patients find solutions much quicker acceptable than the experts. Is that also something I can pull from the graph?
Yes.
Are we then, as professionals, too critical to our work, or what can we learn from that?
No. I mean, when we're talking about aesthetics, then a small difference is for us visible. The question is, do we tell the patient that there is a difference between the teeth of 0.4 millimeters? Because if you alert them to this, then they might find the problem, whereas they didn't know it was a problem before. But the other thing is that if we have a big difference between the neighboring teeth, and we have, as we said earlier, let's say a periodontal inflammation, an ease between the neighboring teeth, then if the patient doesn't know it, then he has or she has to know it, because this plays a danger for the prognosis of the implant. So exactly. We might have to play it a little bit diplomatically when it is purely aesthetic, and then let's go back to patient-oriented outcomes and see what the patient actually says that there is a problem, but still check the patient regularly after implant placement and see if there is some objective reason that you might have to reconsider what you're doing.
Exactly. Very clear, good and well explained. I'm enjoying your explanation. So I'm going to throw one more question at you. Roger Matar, you heard of him before. He's also thinking along like, okay, I've taken in this knowledge now, and what are my clinical scenarios? So he writes, do you consider, and we touched on that briefly already, do you consider bone augmentation or regeneration at a young age? Like I said earlier, can we anticipate this growth?
Okay, bone augmentation, I would be the least, I mean, not the right person to talk about. I mean, we have done some work with Nadia Neni, for example, to see about lateral bone augmentation, but you cannot ask me for that. Early bone augmentation, let's say if we have a young patient, you don't need it because the patient hasn't lost a tooth for that big a period. You have some experimental procedure for augmenting the bone, like, for example, experimental procedure of bringing orthodontically a bone in a region where the tooth has been lost. So you can bring the bone with the tooth and then move it back again. You can, because the tooth, when we move them with braces, and they bring their own bone. So you could actually generate some bone, but if this bone is enough for the implant, then it's a big discussion, and I'm not the proper person to talk about it. So I think generally early bone augmentation, it doesn't make any sense, because anyways, if you're gonna wait until it's not a replacement and it's mostly an adult placement of implant with 25 or 30 years of age, if you do any augmentation with 18 years of age, it's gonna go out. It's gonna go away. Mm-hmm. As we said before, when you don't have any tooth or any implant there to hold the bone, then the alveolus will resorb itself. So I take it, even though you have to ask the implantology experts, that the regeneration would be around, let's say, 6 months before to implant placement.
Exactly. Well, and again, you refer to this is a conversation of multiple expertises. I just spotted in the chat Mitchell Pierce from New Orleans. Mitchell, good afternoon to you as well. Welcome. And also GB Tougnay is writing up a case and asking a question which is slightly off topic, GB. So let me invite us all one more time at the when we are nearing the end of this Just Ask session to meet up in Geneva Thursday, October 29th to Saturday or September 1st. No, November 1st. I'm messing up my dates. Let me say that properly. It's Thursday, September 29th to Saturday, October 1st in Geneva, Uniting Nations Through Innovations. And if you register now before September 20th, you can still benefit from the preferential rate. If you really cannot make it to Geneva, then make sure at least you join our online program on those evenings as well. Spyros, wrapping up. If there's one or two things that you really hope people take away of tonight's session and into their clinics tomorrow, what would you really like to underline?
I mean, it's going to be the same conclusion as it was in the Swiss dental conference. It's going to be the same conclusion it was in the European Federation of Periodontology workshop last year, and it has to do with treatment of adult patients. So it's a very difficult matter. You have to find the bridge between scientific evidence, clinical expertise, and also what the patients tell you. Because we know now, for example, that you can expect biologically to have some differences. You might, for example, from your own clinical experience, see that some patients react better than others. And also there is a big question about the patient, what he wants right now, and what he is going to undergo for the next 10, 5, 15, 20 years of the next in the future. So it is a very complex field. You have to collaborate with different colleagues. I cannot overemphasize that this is not something for young colleagues who have no experience. So it has to be experts in implantology, experts in orthodontics, experts in prosthetics. So you have to have different specialties that all come together. They share their own therapeutic protocols, and they also talk with the patient and ask them what is important for them now, what can they go, for example, as a compromise for the next couple of years, and then always inform them about different scenarios, different problems, different benefits they're going to have. And in the end, it's the patient who will tell you, no, I will do it now, no, I'll do it afterwards. So we have to be a common team with all different colleagues and with the patient. And then don't forget that we still know some things about the age of the patient, but we still cannot, for example, do a blood test and tell the patient you're going to have a stable implant. This is futuristic, so something like a Blade Runner scenario. But theoretically, in the future, you could expect to, depending on the race of the patient, on the growth of the patient, of the age, on the sex, on any other genetic predisposition, you could theoretically then tell the patient that now is the proper time, but there is no clear-cut answer for us up to now to tell them now is the best time. So theoretically, if you could have all patients above 40 years of age having an implant that would be the best, I can expect that a teenager who has lost his front tooth with 12 or 13 or 15 years of age, they won't wait until 40 years of age. I wouldn't wait either, if really honest. So it has to do with what the patient has, what is, for example, the position of the front teeth, what are the aesthetic expectations, and then altogether try to find a solution which is the best for the patient and one you can live with in the long term.
Exactly. Well, very well summarized. Thank you so much for being our leading experts tonight. Spyridon Papageorgiou is your full name. We call you Spiros. Yeah. And on behalf of our audience, compliments to our audience who was so active tonight. I read Ricardo Heine says, thank you from Brazil. So we truly have a global audience again. And even if you just only said hi and checked in, at least it's nice to know that you were all here. I look forward to welcome you all back either live in Geneva in person or online during the EAO Congress. And if you know anybody who should also learn about age considerations around dental implants, make sure you share the link of this YouTube video in your networks, on your social media, with your colleagues, with your professional friends. So together we can advance the field of implantology as much as we can, because that's what EAO stands for. Spiros, thank you very much. And to everybody else, make sure you subscribe to the YouTube channel so you'll be the first to know when a next video is coming online. See you again.
Have a nice evening.